three West African countries, Ghana, Burkina Faso, and Niger, are teaming up to combat non-communicable diseases, hypertension, diabetes, mental health disorders, among others, which make up NCDs, rising in West Africa and requiring urgent steps to address it before it becomes a full-blown crisis. In Burkina Faso, 1 in 5 adults are affected by poorly controlled hypertension. In Ghana, claims for basic anti-hypertensive medicines are within 10 most frequently prescribed, reimbursed under the National Health Insurance Scheme. So to address this, health experts from the three countries have teamed up to provide some interventions. They are currently in Accra to fashion out strategies for this. In the studio with me this afternoon is Professor Irene Ajipon, public health specialist with the Ghana College of Physicians and Surgeons and Dodowa Health Research Center. She specializes in health policy and system. Also, Professor Tulip Bekosi, did I get it right? Thank you so much. Is a professor of global health policy in the Department of Global Health and Development. His expertise covers health policies, health system, and capacity building. And we are going to have a discussion on this very important matter. Non-communicable diseases. And this week I've had time to talk a lot about hypertension. I mean, on Tuesday, I had a discussion about diabetes, end-stage diabetes, one of the contributory factors. So hypertension is a very, very important subject, and that is one of the focus. But how dangerous is it, especially for these three West African countries? Let me start with Professor Irene.
Thank you very much for the opportunity and good afternoon to your listeners. Yes, it is a problem for us, and especially so because the numbers are increasing. And it's also a worry for us because both hypertension and diabetes are diseases that we call ambulatory care sensitive.
Break it down for me.
Yes, ambulatory care means walk-in outpatient care.
Okay.
So when a disease is sensitive to walk-in outpatient, it means if you have very good primary care, you reduce the complications and the deaths. The person can lead a healthy, normal life. But our primary healthcare systems are not adequately focused on this rising problem.
And sir, I mean, the bottom line is the fact that a lot of people walk around without knowing their health status. And that for me is key. So how are you dealing with this?
Well, I think the key is for people to be aware of these conditions. And in our research, we're actually kind of calling them not diseases, but conditions.
All right.
These are longer term issues that people live with, people go to work with, people grow up and grow old with. So from that perspective, it's important to just be aware and manage those appropriately.
But is there a relationship between, for example, hypertension, diabetes, and the other non-communicable diseases?
Well, many non-communicable diseases, they're interrelated. For example, research clearly shows that many patients who are suffering from diabetes or hypertension, they also exposed to some of the mental health conditions, in particular stress, anxiety. So this issue of what we call the comorbidity is really important, and that also paves kind of the agenda for us not to treat each individual disease or condition in isolation, but look at the person as a whole and promote more holistic care.
So for the three countries, what is the strategy you've put together to combat this? Let me come to both.
Okay, so what we have been trying to do is that we think the best solutions come from the people who live with the problem. So over the last 15 months, we've been doing research in the three countries, and we've been reviewing the literature, trying to understand what are the issues, what are the drivers, what are the triggers. And now we've synthesized all that evidence. But instead of them sitting down by ourselves and then coming up to tell everybody this is what you should do, we are now starting what we call co-production. That's we are sitting down with stakeholders, engaging them in discussion and dialogue. Here is the issue, here is what we have found. If you have understood us, looking at yourself, looking at your community, what are the solutions that will work for you in context?
Perhaps we can even talk about the drivers first.
Yes.
So if somebody is watching and some of these symptoms are what the person is seeing, then you can take immediate steps. So the research, in terms of the drivers, what did the research find?
Okay, so I'll use a simple diagram that we have constructed and try to use lay language.
Sure.
So we've kind of clustered the drivers into what we call contextual or macro level drivers, health and other systems, health systems, non-health systems, and then community, household, and individual. And we point out the fact that they don't work in isolation. Let me use an example. Let's say something like the community in which you live. And this is all coming from the research evidence. From the people in urban communities, some of them knew about that you should exercise, eat well. But the problem they pose to us is that there are no pavements on the road in my neighborhood.
For them to exercise?
To walk, just to walk.
Okay.
Or even if there's a pavement, the motorbikes and the bicycles are competing with me for the pavement. I go for a walk to prevent hypertension and diabetes. I may die from a road traffic accident, so I just don't go. So something like this it's a contextual factor, but it's also other systems, roads and transport. So you kind of need to look at these factors together. So I've given an example. Another example of contextual factors, our colleagues in Niger were saying, for example, that the coup and the matters arising has affected health.
Because they are mostly home and they are unable to have access to health facilities.
The borders were closed. It affected, medicines, things like that. Some of the insecurity in the Sahel means we can't even reach those. Again, it's a contextual factor, but it's affecting health.
Right.
And then if you come to the health systems factors, across all the 3 countries, the issue came up if people have to pay out of pocket for service, especially for very poor people, they are just not going to use it.
They don't have insurance as well.
They don't have insurance. They are going to wait till they get a stroke. Then it's too late. And then the other interesting thing that came out is that in Niger, there's no health insurance. So they were saying we need health insurance.
So for them, it's a cash and carry system.
It's purely cash and carry. But then Burkina Faso also said we actually have insurance, but hypertension and diabetes are not in our benefit package. So for these conditions, it's still cash and carry. Then in Ghana, we said we have health insurance, and these conditions are in our benefit package. But some of the implementation arrangements means that some patients were saying we don't have access. We don't have access because we go to the facility and they tell us, I've stocked out of your medicine because I haven't been paid by NHS. So all 3 countries have different problems to solve related to out-of-pocket fees and so on and so forth.
So how are you working around these challenges that you have identified?
Well, we're involved in a 5-year program. So we are reaching this stage, the first of the 3 stages, during which we have analyzed the problems, the drivers of the NCD crisis in 3 countries. And what we're reaching is the second stage of the co-production, which Professor Ejapong has just mentioned. So when we engage with key stakeholders, policymakers, communities, health workers, to actually put the problems in front of them and give them an opportunity to actually come up with solutions. And then in the third stage, we will implement those interventions and we'll evaluate effectiveness of those actions.
Right. So, Prof, for example, Niger and Burkina Faso, where they have issues of, access to healthcare, and they are facing financial difficulties. Some they have health insurance card, but it's not covered. Some it doesn't exist at all. And you have poor people who are struggling to make ends meet. So what is the recommendation for such governments or health institutions or policymakers in terms of addressing this matter?
Okay, so again, like I said, we have thought through, we have some ideas, but at this point, we really wanted to avoid saying you must do A, B, C, because what happens is that people will think, the researchers have said it. But we really want to hear from them. And if I can just use an example from previous work. Many years ago, I was evaluating health programs in Upper West and went to this very poor village. And they said part of our health problem is our poverty problem. And an NGO came to help us improve our livelihoods. And we said, what happened? They said, well, they didn't ask us. They just showed us how to make, I think, both float and tie-dye, and said if we sell it, we'll make money. So we learned and we made it, but nobody in this village wants to buy buffaloes, and nobody wears tie-dye. So we are back at square one. So then our next question was, okay, now let's ask you, how would you have solved this problem?
Right.
They say we are farmers. Our fathers were farmers. Our grandfathers, we like farming. Can you give us irrigation? Can you give us agricultural extension workers? And I'm using it to illustrate why we are not trying to tell people at this stage. We are kind of asking people, talk to us. You've heard the problem. What do you think? That's the way we are going about it right now.
But would you say that there are more people in danger of slipping into end stage, for example, hypertension, diabetes, and other opportunistic diseases that come with it?
Of course, these are the real dangers, particularly if the earlier stages of those conditions are not properly diagnosed. And it is important to have robust systems of screening, identifying the problems early on before they escalate into something a bit more major and less manageable. And hypertension and diabetes are not always working in isolation. We talked about them being kind of also coexisting with some of the mental health conditions and some of the others. So it is important not only to diagnose them early as possible, but also to identify the associated conditions as a package rather than kind of treating each condition in isolation.
But Prof, what is the situation in Ghana? What is the Ghana story?
The Ghana story is similar, and if I come back to what we think, because, for example, I think Professor Mezov mentioned the fact that it's known from the literature, we observed it in our study, that when people are living with chronic conditions, in fact, the levels of depression and anxiety can be high.
Right.
So, for example, one of the questions we are asking and saying, think about it, why is it that in the health system, it is not possible that at every hypertension and diabetes clinic, you screen for stress, anxiety, depression, so that you catch people who are stressed out by their condition early. Because once they get into the stress, anxiety, depression, they may even stop taking their medicines, which then makes the condition worse, and it's said, so that's the kind of thinking that we are doing now.
And how is it going? Is it receiving the needed attention?
Oh, we think as we talk to stakeholders, it will. Just like we are here today talking to you, the first step is to get people aware and talking about the issue. Because one of the big problems we found is that NCD have been on the margins. It's not central. No, we are worried about malaria and TB and COVID and things like that. We felt NCDs are the problems of the rich.
Right.
It's not that way anymore. The bulk of NCDs are now in the low and middle income countries.
You have people very young age, contracting.
Very young age. Sometimes you are surprised, 40 years a stroke, why on earth? But the problem has caught up with us.
And mostly also it's about lifestyle.
Some of it. Some of it is about lifestyle, but some of it is also about enabling a healthy lifestyle. Like the example I gave in urban areas. These people we talked to knew they should exercise. But their question is, will my exercising make me die rather than so I'll sit at home? It's an enabling environment.
So Prof, is this your expectation that after all this is said and that we expect policymakers to take your report and implement them?
Well, it's not as simple as that, as we all know, because researchers can always come up with wonderful ideas, but the policymakers, they're often under immense pressure to use fairly limited resources for the public need. But what we're hoping to achieve is, first of all, to raise awareness of the NCDs in the 3 countries. Secondly, to actually kind of advocate for real change. And the real change doesn't always come from the policymakers. The real change will actually come from people, because people often underestimate their power and agency in actually using the specific type of services, engaging with kind of healthier lifestyle choices, and actually avoiding those diseases to escalate into something major. Just to give you an example, I think one of the really strong findings that was coming across all 3 countries is related to escalation of the hypertension, diabetes, and associated mental health kind of conditions into something which is unmanageable and which is often subjected to a huge amount of stigma. And it's almost a vicious cycle. People are unable to actually engage with healthier choices because they feel that the society doesn't kind of treat them, or indeed kind of they're unable to engage with healthier choices. And what we would like to engage with is to actually reverse that cycle, to kind of break that cycle. But at the same time, I think policymakers are important, and to be fair, in all three countries, there are NCD policies. They're beautifully written documents. They're strongly, kind of logically, kind of flowing, appropriately, kind of structured. But I think the implementation often kind of suffers just because people don't subscribe to those, or indeed health workers do not have the opportunity and means, such as resources, to actually implement those. So what we're trying to do is to intervene at all levels of this kind of multifaceted problem.
Right. Professor Ejapon, final words. So after the 3-day program, what do you expect going forward?
In fact, going forward, we are going to continue what we are doing now, dialoguing with stakeholders at community level, at facility level, at national level, presenting these findings, discussing what solutions can work in context. Because the other thing is, we may have a perfect solution, but in context it may not work. So we really need to come to feasible solutions that work in context, despite the fact that you're a very poor country. For example, something can work. What can work given your situation? You may not be able to fly to Kumasi, you can't afford it, but you can still get to Kumasi by bicycle. It may be a little slower, but we'll get there.
All right, thank you so much for coming through. And we have been discussing non-communicable diseases, and there's an ongoing conference here in Accra between Ghana, Burkina Faso, and Niger, and the outcome they hoped that policymakers and those in this space will take it up and then deal with this matter head on, so that we can deal with these underlying issues. This is a